I at least was admiring this beautiful little living room setup. I wish I had this in my house. It's really nice. So what we're going to do now is we're going to have a discussion based on some themes we heard. I have a question to throw out for you, and then what I'm going to do is I'm going to ask some questions from the audience which fall into, I would say, 4 broad themes. The themes that I see in your comments, big ones, and I apologize that we probably won't get to cover every single person's question, are privacy and security, issues around disparities and reaching the underserved, culture transformation with particular emphasis on Stacy's remarks, and looking at broadening the idea of health, going beyond some of the traditional measures that we think about to bringing in other aspects of our lives. Excuse me. So before we jump into some of those topics, Robin especially, but this I think actually is a really good question for Billy too, talked about how many folks outside of Washington are unaware of the amazing resources that are created not only by the federal government, but also by foundations and others. Some of these resources, they could be funding sources. Certainly I know as a government employee, I get a lot of phone calls about that, but there are a lot of other resources that are very rich out there. Sometimes people don't know, and there's a little bit of a disconnect about how the private sector and others can ingest them and make the most of them. Do you have any comments or thoughts on that one?
Lots. I'm sure Billy has more. Just to continue on what Billy was saying is that the Affordable Care Act has a ton about prevention, and really I'm passionate about prevention. Actually, the Bipartisan Policy Center, we just put out a report on how to get medical professionals to learn more about nutrition and physical activity in their training. But one of the things, I got hired by Welltalk after working in the nonprofit sector and the government sector for over 20 years to work in the business sector, and it's a total new experience for me. Oh, can't hear. Can you get, oh, now you can hear me. Okay. So I'll just summarize what I was saying before, is that having worked in the federal government and with nonprofits for many years, when I got hired at Welltalk, a private company, a technology company working in healthcare, I was shocked how little they knew about the resources that were available at the federal government level. And that they had no idea about nonprofits like the Colorado Health Foundation, like the grantees that they do. And I know Welltalk is not alone. This happens all across the nation. So one of the things that I am tasked with doing is finding out what is available in the government sector and the nonprofit sector that can be translated to the business sector. And one of the problems that we have, I think, why there is this siloization is we don't talk in the same business models. We don't talk, or nonprofits and the government don't necessarily have a business model. So if you're trying to do something in the business sector, you can. So one of the first things, so if you work in the federal government, you know lots of acronyms, tons of acronyms. You know, that's what you do all day, ACA, DOD, HIPAA, whatever it is. So one of the first acronyms I learned working in the private sector was PMPY. Does anybody know what that is? No? I'm shocked. You do. What is it? Per member per year. So does anybody know what that is, per member per year? Yeah, so it's what a health plan will pay for a program per member per year. And so when I started talking about these great programs like Cooking Matters, that share our strengths, that teaches people how to shop and cook, or Wholesome Wave that works with farmers markets, or the Alliance for a Healthier Generation that works in schools to get healthier schools, the question I would get is, well, what's the PMPY? And I'd say, I don't know. So one of the things that if we want to leverage resources, I think, is if we look at all the great information that's out there from the federal government or state government or foundations, is that one, how do you translate it? How do you translate that information into a consumer model? If you go to like a CDC website, there's lots of information, but the way you receive it, it's not very consumer friendly. And so that is a challenge. And then the second is if you're a nonprofit or if you're a foundation funding a nonprofit, is there a way that you can take their program and put it into a PMPY model and then offer it to insurers for beneficiaries, whether it's for Medicaid, Medicare, whatever it is, because that's a language that an insurer understands. And then also it's a potential revenue stream, so a foundation doesn't have to fund that nonprofit for the rest of their entirety. So it's one of the things, that's one of the lessons I've learned of switching from federal government to the private sector is we don't talk in the same language, and how do we get these business models or the value propositions to be more similar so that we really can transform health and really get to better health outcomes.
Totally agree. Good insights. Billy, do you have anything you want to add?
The only thing I would add is I think one thing, first of all, of course, there's a ton of commerce between the private sector and the government that's going on. But I think that one challenge is that you've got sort of different doors to go into. And so instead of going to a website that says, oh, you build a widget, or oh, you're an insurer, or whatever, and then here's everything that you should know about what's going on with the government, including opportunities for you in your business. You've got to go to the CDC, and then you've got to go to HRSA, and then you've got to go to ARC, and then you've got to go to this and that. And so I think, if you haven't noticed, I noticed because my site does it, but there's a trend in the web now of aggregation, content aggregation and curation. And so I think that whether the government does it or the private sector does it, that nut's going to be cracked pretty soon. And it's going to present to the consumer or the business what they need to know from the government, rather than you having to kind of root around for yourself.
Yeah, so I'll just comment on all this too, that there's something called the Open Data Initiative, which is a push to get government agencies. There was actually a presidential proclamation a couple years ago about how federal data needs to be increasingly shared and put out there in a way that the private sector can use it and ingest it. And that's the kind of thing that actually we work on in the Blue Button Initiative, but it's a lot broader and it goes beyond health. So this is a movement, but I totally agree with you both that there's a huge amount of work to be done in making sure that translations actually occur and that people know of resources and can use them.
If I could just add, it's really it's viewing it from the consumer. Mm-hmm. So if you go to Colorado, for example, that has Department of Health and Environment and the Department of Human Services. So every state, the way they silo their programs are in different departments. So your Medicaid and other services or early childhood may be in the Department of Health, but another state may have it in another department. So your programs are offered based on the siloization and the appropriations that you get from the state government, as opposed to if we're changing consumer engagement, we have to think, I'm a consumer. If I don't know which department, who has the resources, I shouldn't have to know that. I should just be able to get that information pretty easily.
Yeah, excellent point. So I want to move to the first of these big themes that I saw a bunch of questions on, and that's privacy and security. So one person writes, how do you assure privacy with all shared data so that it is not used for discrimination? There are a number of questions specifically about Blue Button and the Blue Button Initiative, so I'm going to take those and then let my co-panelists here answer any additional comments with any comments they'd like to make. The thing that's neat about the Blue Button Initiative is that you are getting data about you that already exists. You're not like creating a new electronic store of data. The point is there are health plans or your doctor or a pharmacy who's already got your records. There's a ton of electronic information about you and your health floating around the ether, whether you like it or not. Don't you want to see it yourself? Get it yourself, see what it is, and once you have it, you can decide who you want to share it with, if anyone. That's not to say there isn't plenty of other sharing going on outside of the Blue Button Initiative. There is, and there are laws, particularly the HIPAA privacy and security rules that govern how that's done within a healthcare setting. A little bit of the Wild West is when information moves, as it increasingly does, from that healthcare setting, or maybe not just within your hands if you've downloaded your own data, but what happens when you go and plug that into an app or a tool, or you share it with a company that is not a HIPAA-covered entity? You're kind of going out into that like unregulated area. I shouldn't say unregulated. There are some laws and rules that apply. The FTC, for example, has jurisdiction to cover privacy policies that are posted by any kind of entity on the web. So when people say what they do in a privacy statement online, they can be held to that. But that is an area of, I would say, emerging. Well, buyer beware. It's not all sort of worked out yet, and you need to be thoughtful as an individual when you pull things out of a HIPAA-covered context, what you do with your data. It's sort of the basics in some ways, like don't put your medical record on Facebook, probably. That it might be appropriate for some people, but maybe, there are risks associated with that. So some of that is your own knowledge. It's starting to know about privacy policies, and my own personal opinion is that the federal government could and should do more in partnership with the private sector to construct not only agreed to sort of appropriate codes of conduct for how to handle information, but maybe some real guidelines about how to do that appropriately. So those are my thoughts. Does anyone want to add to the kind of privacy and security question in general and this quite appropriate angst that a number of folks are expressing on these cards?
I think for us, like looking at it from an organization's perspective, I mean, this is a huge one because to really instill patient engagement, there's lots of ways you can do it. One of the ways that we've found to be quite successful is putting the information in an individual's hands, which is what many of you guys have talked about today. And so where we've gotten caught, and we're still getting caught, is this idea of what connects to what and what you can put in a cloud and what you can't put in a cloud, and it causes just incredible bureaucratic red tape. So I feel like sometimes we back away from potentially great patient engagement opportunities because we're trying to be so mindful of the what ifs. And I think, just in talking to other healthcare organizations, we look a lot toward people like you and toward governing organizations to help us navigate that. I think it'll be really interesting to see what happens over these next couple of years because this push for patient engagement has to come to terms with this push for what's appropriate data, what's data safety, how can big data be used effectively in population health while still not, while not violating individual rights. I think this is a very murky area that as a provider we're excited to kind of sit back, I guess, a little bit and see how it shakes out, but it's certainly on our radar.
I guess I would comment too, I feel like this area is only going to get in some ways murkier and harder as not only more information is shared, but more information is created. You talked about big data, and increasingly we're going to have sensors in every piece of our clothing and sensors on the doorways that are, measuring your body temperature as you walk through, and maybe even identifying that you're sick before you do. I've heard about, for example, software, and I bet Watson can do this, that parses language within books to show that the author may be suffering from early signs of dementia. Things like that, in a way, make obsolete the questions of like, what's in your health record? Like, yeah, that's important, and it will continue to be important for a number of years, but I think we're going to be dealing with a whole new realm of privacy and security related questions over time.
Well, I think that makes a great point too, because then it's a matter of meaningful data. So how do you keep that pendulum from swinging completely the opposite direction, where now we have people seeking healthcare advice, appointments, time with clinicians to talk about something that came up on one app somewhere that might suggest something. Yeah. I think you make a great point around it might get a little murkier before it gets clearer.
Buckle your seatbelts. So another murky topic that several folks asked about was the issue of disparities, different populations, either in the context of the digital divide, people not having access to technology, or different populations not having access to care. So let's see, somebody asks, we've talked about how much zip code matters for health and the need to address health disparities. How much do different populations use mobile technology, social media? Do they have internet access at home? How do we address that? I also want to throw in there a specific question about Watson, which I don't know if you know, but the question is, has Watson been or could it be fed languages and cultural information to be able to deliver really targeted health information? So any thoughts for you guys on this whole set of issues? Billy?
Okay. I'm scared to say it, but I'm glad you asked because I wanted to say something about this. So yesterday, the National Quality Forum announced that it was backing off of an expert panel's recommendation that came out in March to account for socio-demographic factors in adjusting quality metrics. And the expert panel was commissioned by CMS, the Medicare and Medicaid agency, through NQF to look into what is very clear is a fact, that your income level impacts your health outcomes. For example, where you live impacts your health outcomes. A variety of factors that are not sort of specifically related to your health impact the outcome of your health. But currently, NQF endorsed measures, which comprise basically all of the Medicare and Medicaid measures for starters, do not account for those factors in evaluating plan and provider performance in treating patients. And so what happens then is that providers who treat a disproportionate number of, for example, low-income patients have worse quality scores, and under these new programs get penalized for it. And similarly for plans, and actually a lot of Medicare Advantage plans, the commercial plans in Medicare face termination this fall, and many of them care for example, dual eligibles, folks who are eligible for both Medicaid and Medicare, and therefore by definition low income, because they have failed to achieve the same measures that plans that treat the broader population treat. Now, I caveated that because we could spend a lot of time talking about this. I feel strongly about it. I personally think that the NQF gave in to pressure, and there's a lot of pressure on the other side that I think does make a lot of sense and has to be taken very seriously, is that you don't want to dumb down the score for the providers who treat those patients, right? But you don't want to create the perverse incentive of defunding providers and plans who need it most. So it's a tricky nugget to crack, but the current policy, I believe, is having unintended adverse impacts on patient care.
Is it working then? No. I'll add the technology side. Just to answer the specific question about Watson and then talk about technology, is that Watson, yes, can ingest languages and cultural differences, and so the next phase for Watson is to really ingest information from the Romance languages, and then we'll go on to other languages. So yes, it has the capability of doing that. But what I would say is actually Colorado, the Medicaid office put out a report not long ago in Colorado that you would be surprised the amount of Medicaid beneficiaries that have smartphones and that have mobile technology. Now, they may not have a computer and they may not have internet access, and it starts to skew younger too. So the younger the Medicaid beneficiary, the more likely they're going to have a smartphone or they're going to have a mobile phone. And so text messaging becomes very, very important. I don't know if you're familiar with, there's a great program like Text for Baby that sends out texts on a regular basis when you're pregnant. So there is a lot of opportunity to use technology, and even when we think of health disparities, just because you're low income doesn't mean you don't have access to technology. So there's much more data that's out there supporting that people are using technology. And as I said in my presentation, if we make it simple and easy and meaningful and speak to those audiences in a way that they care, that it really speaks to what their values are, then we're going to have technology alone. Just having the technology is not the only important thing. It's how do we use the technology, and what messages and what actions are we asking people to do is on the forefront.
I mean, I would say too, technology is very customizable, and it's easier to customize an online or a digital experience to meet diverse needs than it is to print something multiple different ways in different languages and different font sizes and with different images that may appeal to different groups and so on. So there's kind of an opportunity here, I think, to really address some challenges that we faced in the past in reaching different communities, if we can do it well.
Right.
But I wonder, Stacy, do you have any comments on how the Cleveland Clinic has looked at reaching diverse and particularly underserved populations?
You know, it's interesting because for us, when you look at diversity on a spectrum, we don't have a very diverse caregiver population and we don't have a very diverse patient population. So to really look at this, I think, meaningfully within the Cleveland Clinic lens, you need to expand beyond the walls of Cleveland, Ohio. And so when I think about this from the perspective of our organizations, our hospitals, and the United Arab Emirates, there you've got incredible diversity. It's an 80% expat area. So you've got incredible diversity both in caregivers and in patients seeking treatment. And as much as I'd love to tell you, hey, we've got a great answer to this, we don't. We just simply don't. We're focusing very much on what are the similarities, and then we're driving technology around those similarities. And I think to your point, like Gia, from there it really becomes customizable a bit. So you can make it more individual by pulling it out, making it a bit customizable based on some of the diverse factors that you're identifying. But the core of it needs to be very commonplace. Otherwise, you lose the messaging. So conceptually, I think we're there. But in terms of how to best operationalize it, I think we're a work in progress.
I would say too, it seems to me that customizing for different communities or populations is a burden, if you will, that say the Cleveland Clinic shouldn't take on its own. We need to engage the community that you're trying to reach in figuring out how to reach them. Otherwise, you'll just do it wrong.
Right.
It's like what you were talking about with the soldiers, and saying like, be healthy or whatever. That doesn't work as well as how you switch that messaging in a way that really resonated. But you're not going to know ahead of time what works. The other thing that's interesting is sometimes you survey and test what's going to work, and it's not actually what works in the end. So as an example, and someone was asking about how much we've tested Blue Button, and we have done some initial testing and how to message about it, but there's a company called O-Power, which is measures electricity use and other energy use, and they were working with the problem of how do you encourage people to use less energy? And they did a survey of their population and said, would you be inspired by statements that say, for example, use less energy, save the whales? And they were, and people were like, oh yeah, I care about the environment. I'm very, motivated by the vision of the whole thing. And then they asked or would you care, what your neighbors are doing? And they were like, whatever. It's not about peer pressure. I'm driven by these, lofty goals. But in reality, when, for example, people have tested that whole thing about should we rewash your towels when you stay in a hotel, it turns out that the messages that are most effective for the general public, and O-Power found this to be the case too, are not the lofty kind of save the world messages, which tend to be very abstract, but did you know that you're using 40% more electricity than your neighbors? Or the last person who stayed in this room didn't rewash their towels. Are you going to? That's like, oh, well, okay, it's personal and I want to do well. So that's, the kind of thing, it's really interesting, I think, sort of.
Well, they used that in the last presidential campaign.
Yeah.
So
Pick up your microphone again.
Last presidential campaign, same thing. Did you know that your neighbor voted?
Yeah.
And
so hooking
it
into
becomes this peer pressure.
Behavioral psychology to think about how you reach different populations and help them get motivated to do what they ultimately want to do and what from a policy perspective you want them to do is a really interesting area of opportunity, I think. So while we're asking Stacy questions, there are a few specifically for her. So some questions about the Cleveland Clinic. One is, how do Cleveland Clinic ratings compare to those of non-US medical centers in the 12 developed countries? In overall health status, somebody just kind of wanted to get a sense of how are you doing on a worldwide basis, but not just relative to the developed countries, but who are, peer organizations, I guess.
Sure. I guess like anything else, it depends on what metrics you're looking at. So when we think about patient experience, this question gets a little bit difficult because The US has standard national metrics around patient experience, and we're finding it very difficult to compare ourselves outside of the walls of the US because many other nations are just at the brink or are struggling with trying to figure out how to measure experience in a meaningful way. So they're really in their infancy around it. What's interesting, though, is despite the lack of comparable metrics, we get a lot of inquiries. And so this is more anecdotal, kind of qualitative input around this question, but people are knocking on our door. And what's interesting is when they're knocking on our door saying, what are you doing about patient experience and how do you do it? And we say to them, well, why are you interested? Since they don't have that data button to fall back on, it's not, oh, well, our scores are really bad. They come at it from very different perspectives. So for example, back to the UAE, the United Arab Emirates, they wanted to prevent outward flow. People leave the country to get health care. They want to provide better health care for their local community. Canada, this has shocked me time and time again. Canada contacts us because they say, we want to improve our reputation. We believe in the holistic approach of patient experience, and we want to improve our individual facilities our organizational reputation. So getting a little bit away from the question in terms of how do we compare, quite frankly, we really don't know based on metrics. What we do know is based on the anecdotal feedback and the number and types of inquiries we get that people care about this even without the hard metric in place, which to me is just fascinating. It makes it seem like this is far bigger concept than just the measure. It also aligns really well with our philosophy on it, which is you don't teach to the test. This isn't about getting good HCAP scores. It's about creating a great patient experience. Your scores will follow. They'll reflect that regardless of your metric. So not a really clear answer to that very big question, but hopefully, a little bit of contextual information as to how we've approached it and how we look at it.
So I got a clearer, possibly a yes or no question for you. It says on the theme of patients first, purchasers formed the Leapfrog group to promote patient safety in 2001. As many of you probably know, it publishes reports for consumers on hospital performance on patient safety, so similar themes. Folks just wanting to know, will the Cleveland Clinic be reporting to the Leapfrog group in 2014?
Right, so we haven't historically reported into Leapfrog. I don't know. It's a yes or no question. Here, let me go with I don't know. I don't know what our status
That's
is.
yes and no.
Yeah, really. Can I answer it all? Can I answer both? For 2014, what I can share, though, is that we had a patient experience summit. We run them every May out of Cleveland, and so we held one in 2014. And Leah Binder, who is the CEO of Leapfrog, was one of our keynote speakers. So certainly it's a very friendly relationship with Leapfrog. I would be surprised if we aren't participating in the near future. Please don't anybody write that down and stream it all over the place. But if I were to guess, I would guess that it's something that we're seriously considering.
All right. Another theme that I think several of us touched on in the presentations, but that also has come up in the questions, is this idea of looking beyond healthcare to health more broadly and thinking about how do you incorporate other measures and other factors beyond the traditional clinical care and measures thereof into health. So specifically, we have a question about mental health and integrating behavioral health and internal medicine in order to improve chronic conditions. So someone gives the example of even things like, encourage people to use sunscreen. That's not something you necessarily hear from your doctor or your primary care physician. Somebody else has a question about oral health and the importance of that. It's my understanding that there's often, I don't fully understand why, but there isn't a lot of sharing necessarily of records between dentists and other kinds of care providers, and people kind of asking generally, how do we bring in these other kinds of factors, and how do we make, I read this as, how do we make healthcare broader? So it's more about health. So anyone want to take that on?
I'll start just from my two hats at the Bipartisan Policy Center and at WellTalk. From the WellTalk perspective, we get hired by health plans and hospitals. So those are our customers. And we have consumers. And what's interesting, what we get asked for all the time is, do you have plans for stress reduction? Stress is like number one. The other one is spine, back injuries. I don't know if you know that back injuries are one of the primary reasons you have absenteeism in the in the workplaces. And sleep is another issue. So we start thinking about, so when we start talking about health and transforming health or imagining health, or what I like to say is the whole you. And so the whole you really encompasses, if we start getting this message to consumers, is what we're doing is that it's what you eat, what Billy was saying, what you put in your body really affects how you live your life, how your performance, whether it's your academic performance, military performance, work performance. So your nutrition, your physical activity, your sleep. Somebody told me some statistic, I'm not sure if I have it right, but if you get less than 4 hours sleep, it's as if you were operating while drunk. So you really are not at a capacity, at full capacity. So sleep is something that often is not talked about, but is a huge impact on our health. And obviously stress management. And also the other one, stress. And mental health is obviously different than stress, but looking at the whole you, of thinking about all those elements, and we are a complex system, and we have to look at all those pieces. And so that's why I think, why we have all these provisions in the Affordable Care Act that talk about prevention. And then, as Billy was mentioning about the Andrew Wiles Clinic, I think there's more and more desire of we have to take a more holistic approach and think about how we live our lives and what we do every day to affect our health. And from what I can see from a Well Talk perspective, we're looking at that as from the consumer messaging that's really resonating, because people understand if they don't sleep, or if they're stressed, if they're not eating right, or if they don't get physical activity, they don't feel well. So they are starting to understand. And then from a policy perspective, I think I mentioned before my mic was on, at the Bipartisan Policy Center, we've been working with a bunch of medical schools that are really looking at integrating nutrition and physical activity as part of the training for medical professionals. And you'll be surprised, we did some grand rounds at Georgetown, at GW, and other places, and the amount of pediatricians and other GPs that came up to us and said, I wish there was more of this in my training. I've had to do this myself to go to other trainings for continuing education, because I really want to help my patients, but I don't know how. So I think there's going to be a drive. There's a drive really from both providers and consumers to really look at the whole you and not just one piece of you.
Billy?
I don't have a great answer. One thing that I would say is talking about it. I mean, I think, especially for people in this room, you have a unique position. You're kind of these hubs and spokes of communication about important ideas. I mean, the government can do some things, commercial enterprises can do some things, but I mean, most of what I know about health comes from friends and family, and the occasional caregiver, and certainly I listen to them. But I think that we should not be shy to talk about things like health and nutrition. I did my little sugar routine. It's like, there's a risk that you sound preachy or whatever, but a lot of my friends don't know how bad sugar is for them, and I care about them and I want them to know. And I don't say it maybe quite like I poured it on you earlier, but I mean, I want to feel comfortable talking about that issue. You mentioned mental health. I mean, okay, there we go. We need to feel comfortable talking about mental health. There are people in this room who are afraid to talk about mental health, and we all know why, right? We're making progress. We're making some progress. There are some federal policies that are mental health parity, for example, that are long overdue, but thank goodness they're there. But I think that's another area where we should not be shy to raise those issues, talk about those issues. I recently had experience working on a federal campaign with advocates who live and breathe in the mental health space all the time, and it was striking to go to Capitol Hill with that mindset. We're like, this is what we're going to talk about, and see the body language and the reaction of the people on the other side of the table when you go into that issue. They kind of get a little bit back, right? They kind of sink a little bit down. It's not something that people want to talk about, so I don't want to belabor it, but I think one answer is to feel comfortable, especially among the leaders in this room, talking about issues like that.
Piling on, we're so bad in this culture about dealing with death. It happens. We need to talk about it. We need to prepare for it better. We need to encourage patients to prepare advance directives and share them with their families. We need to in my opinion, integrate those into health records. So that's another area where some of this is about just cultural change and something we're uncomfortable with. I want to also mention a particular thing related to the area in which I work at ONC, which is that in this meaningful use incentive program that supports providers in adopting and using electronic health records, there's been some discussion about whether in future phases there should be a requirement that doctors have within their electronic medical records fields that address or are able to ingest data from patients. So this could be anything from information that maybe you're tracking from your own heart monitor or your digital scale at home, or it could be something like tracking your moods and having a way to send that back to your provider so that it's incorporated kind of officially as part of your record and becomes part of that conversation. So I think that's an interesting area to watch, and I would encourage anyone who feels strongly about that to look for opportunities to weigh in on that, particularly now that there's an increasing number of tools that let people measure that kind of thing. Not that people haven't done so before on paper, but when it's digital, and particularly when information can be passively collected, so you don't have to like map everything out by hand, it seems like there are opportunities to take advantage of that data and to think about data use not just being about, you know, data coming from the health system to the patient, but like really looking at a holistic view of what they know about their own health and sharing it back. So other thoughts? Or
just to comment on Billy's point, you know, I think talking about it is huge, and just being able to create an environment where you can have the conversation is the first step. I think the second step then becomes, so what are you going to do about it? How do you operationalize it both at an individual level, and then how do you use your influence to take that to an organizational level? So when I think about the Cleveland Clinic, I think about the incredible attention we got when we said we're about healthy eating. And the way we backed that up was by removing foods with high sugar content and trans fats from our entire healthcare system. Same with smoking. You know, we are serious about smoking. We feel smoking is bad for your health, as you know, substantiated by a lot of research. So we don't hire people who are active smokers. And if you are smoking, I shouldn't say active smokers. If you're smoking, there's a nicotine test. And if you're a smoker, we will provide you support to help you quit. But I think there's also, it gets to a point where it's that action step. And so it's great, and it's absolutely imperative that Billy's talking about sugar is bad for you, and I care about you, and I don't want you to consume large amounts of sugar. I think it's even better than that he's taken that to the next level. And so now he's influential around that platform of how do you instill change at even a bigger level than that one touch point. So I think those are the sorts of steps that all of us in this room can help facilitate, not just individually, but then back in our own organizations. And that's where change really comes into play. That's where movements start.
So I think we're about to wrap up, but I want to give a chance for everybody to give one final comment. And I would love it if you would answer the question in particular, what are you excited about? Where do you think there are opportunities for change and advancement? Like, what are you just really pumped about in health and healthcare? And I'll start just to give you all a minute to think. I'm very excited to see the impact of the ACA. I think that'll change hopefully payment models, change care a lot. It's also very exciting to me to see the kind of change that's occurring both in the private sector, where the world well talk inhabits, and also in the health system itself. The cultural transformation you've described in Cleveland Clinic is amazing. And so again, I personally am sort of getting ready to begin a new chapter in my own career, and I'm looking, I don't know the answer to where this is all going. I'm looking forward to having a little time to trying to understand the fundamental changes in health and healthcare right now and where we're heading. But that to me is really invigorating. So. I
want to get mine out before somebody steals it. I am excited to see, and we're seeing it now. I don't know where it's going to go. It's not going to be pretty, but consumers are taking over healthcare, and people have alluded to it in this panel, and it's in the air. We don't yet have the tools to do it well, both in terms of buying coverage, shopping for doctors and hospitals and our care, and figuring out our health IT situation, using our blue button, that kind of thing. It's getting there, but the movement is afoot. It's not there yet, but there's no stopping it. And so I'm excited to see where it leads.
Cool.
Well, I was going to say a similar thing. Now you said it. But I'm excited about consumers.
Uh-oh.
Guess what? I lost it again. The mic does not like me. I'm excited. I work a lot in nutrition and food, and I don't know if you are familiar with change.org and what that has done, and with petitions. And what I'm excited to really see is people care more about their food. People are asking questions. People want better nutrition facts panels. They are asking about GMOs. They're asking about, what does this food do to me? What's in this food? And there are these two bloggers I just read about in Politico last week that got, I think it was Anheuser-Busch and another beer company, because beer companies don't have to list what's in their beer. So they got them to list their ingredients. There's another young girl who found out there was a flame retardant in Gatorade. That's a little piece of Gatorade that keeps the orange from staying orange and not having a little deposits at the bottom of Gatorade. And she got PepsiCo to agree to take vegetable bromide out of their product. There was, oh yeah, and then they also got Kraft to take some of the food dyes out of the kids' mac and cheese. And so when I think about, I come from the world of federal policy like Billy, and often we're always trying to change legislative policy. But what I'm excited about is thinking about how consumers can drive little p policy. So whether it's the little p policy at the Cleveland Clinic, or it's the little p policy of how a food manufacturer manufactures their food, or if it's the policy of, what do the vending machines look like in state governments or big, large employers or hospitals. I think there's a great opportunity for this little p policy that doesn't really require, as Annie was mentioned, years and years and years of slogging through legislation, that really you can switch a policy pretty easily and really think about family policy. What are your family policies? And my kids, they often laugh because when they have friends come over, they're like, well, you're not really going to get a snack that's not healthy because my mom worked for Michelle Obama, and it's always going to be something healthy. And so our family policy, we have family policies that everybody's got to do 60 minutes of physical activity every single day. There is no dessert during the week that is with sugar. You can only have that on the weekends. If you want dessert, we have fruit. So we have even little P policy in our family. So I'm excited because I think consumers are driving this, but because of technology and the blogosphere, we can have more impact. If I was just a mom complaining to Kraft and wrote a letter, probably nothing would happen. But if 500 moms or 5,000 moms sent a letter to Kraft, well, all of a sudden they took that food dye out. So I'm really excited about that potential of that we're starting to care about our bodies and what we put in our bodies, and then using technology to make a difference.
Cool.
So I'm excited about how our thinking around the change that's happening in healthcare in the U.S. particularly has really shifted. And so when I think about, being invited to participate and share the Cleveland Clinic story on panels and in groups in the past, people sitting next to me were always from healthcare organizations. And so I absolutely love the fact that when you look at this panel, you have got expertise from a lot of different niches sharing their story and sharing their alignment to the same common goals. So whether it's education or policy making or pay providers or hospitals or organizations that are instilling some of this at a very local level, I think it's just an exciting time to be rallying around an incredible cause that resonates across a lot of different disciplines and expertise within healthcare.
Thank you. So it has been such an honor and a lot of fun to work with this incredibly talented and articulate group of people, and also to be welcomed by you and your community here today. So let's give these folks a round of applause. Excellent. And we are going to break now for lunch. We will be reconvening at 12:15 sharp.